pictured there was born with hypoplastic left heart syndrome. I am one of the co-founders of Sisters by Heart, which is a national nonprofit supporting and empowering HLHS families across the country. And as many of you are aware, the Fontan circulation is not ideal. And after we heard about this trial, we wanted to provide a forum for the single ventricle community to learn about the FUEL trial, which will help researchers determine whether or not a certain drug is effective and useful for single ventricle patients. So we felt this trial was important to share because it holds promise for increasing exercise tolerance and decreasing some of the Fontan circulation pitfalls that many of us have heard about over the years. So welcome.
Yes. Thank you, Stacy. And this is Jody Smith-Lee-Max. And I also, like Stacy, I felt like this was a very important trial. In fact, my son Joshua, who is now 13, almost 14, with hypoplastic left heart syndrome, is enrolled in this trial. And we also at Mended Little Hearts, which is a national nonprofit for providing hope and support for families with children with heart defects, feel it's very important to get this information out there to our members. So we are glad to be here today. And without further ado, Dr. Goldberg will tell us about the trial itself.
So thank you both very much for organizing this and for inviting me to speak with your groups. It's really an honor to do this trial and also to do this presentation today. So this is a trial that's been in the works for a large number of years. Basically, the motivation for the trial is to try and improve outcomes for children born with single ventricle congenital heart disease. So I'll take you through a whole series of slides with some background on the way we think about the Fontan circulation and then some more details specifically about this study. So this presentation is really, although Steve I don't believe is joining us today, it's a presentation from both of us on behalf of the team of Pediatric Heart Network investigators. So just a quick word about the Pediatric Heart Network. Many of you are probably familiar with it, but it's a network of centers interested in the care of children with congenital heart disease around the country, and really now including sites around the world. There are a couple of sites in Canada, and for the FUEL trial, a couple of sites in South Korea as well. Some of the major sites, so you can see a picture here of all of the sites that have been involved in Pediatric Heart Network trials over the years. For the FUEL trial, we've even added a few more. So in this talk, I'll give a brief overview of single ventricle palliation, talk about the impact of the Fontan circulation on the heart and the lungs, a history of drugs used to dilate the blood vessels in the lung circulation, specifically in patients with Fontans, and then talk a little bit about the FUEL trial and the FUEL-OLE trial, which is open label extension. So this is a demonstration of hypoplastic left heart syndrome, which is one of a large group of different congenital heart defects marked by the presence of a single effective pumping chamber. In the case of hypoplastic left heart syndrome, the primary chamber is right ventricle, although there are other types of heart atresia, double in left ventricle, where this is a left. Prior to 1945, survival was possible, but only for a small fraction of patients with single ventricle heart disease, and even in those cases, those patients would have profound cyanosis, with very low oxygen saturation. In 1945, two doctors by the name of Blaylock and Taussig introduced a systemic to pulmonary artery shunt. This is now for those who have children who underwent stage 1. This has evolved into the modified Blaylock-Taussig shunt or modified BT shunt. But in the original days, it was done surgically by turning down the artery that goes to the right arm and connecting that artery directly with the pulmonary artery, so that rather than feeding the right arm at all, that blood would now feed the lungs. And that allowed for increased pulmonary blood flow and decreased cyanosis. In 1950, Dr. Glenn at Yale and others introduced the concept of the direct superior cavo-pulmonary connection. This is what's evolved into the stage 2 operation, or often called the Glenn shunt. Creates obligatory pulmonary blood flow from all of the blood now from the upper body, the arms, the head, and the trunk, drains through the superior vena cava, which is connected directly to the right pulmonary artery. This allows for improved oxygen saturation and a much more stable circulation. Then the final sort of chapter in this evolution was in the early 1970s. Dr. Fontan and Dr. Kreutzer both independently described what they termed a complete physiologic correction of tricuspid atresia in their case, which was the inferior cavo-pulmonary connection, or the connection of the inferior vena cava, or that blood anyway, directly to the pulmonary artery. For whatever reason, this became known as the Fontan operation and not the Kreutzer operation, although there are some people who still refer to it as the Fontan-Kreutzer operation. And this allowed for survival of a subset of patients with a relatively normal oxygen saturation. So this series of innovations over the last 70 years has now led to a generation of survivors with what we term Fontan physiology. So what is the Fontan? Well, the way that we refer to it in our institution is as a total cavo-pulmonary connection. And what that means is that all of the blood from the superior and inferior vena cavae are connected directly to the right pulmonary artery. So cavo-pulmonary connection, total cavo-pulmonary connection, and that's what's seen in this picture here to the right. So systemic venous blood, the blood that's been used by the body and is coming back, now goes directly to the lungs without the benefit of a subpulmonary pump. So in people with two ventricles, the right ventricle serves the job of pumping blood to the lungs. In those with a Fontan circulation, there is no ventricle to pump blood through the lungs, and so it drains passively through these surgeon-created connections. So this allows for survival with relatively normal arterial oxygen saturations. So for those who have had a Fontan, particularly those without a fenestration, the oxygen saturations will be in the range of 93 to 97 or so. And for those with a fenestration, more in the range of 88 to 93 or 4. So how are we doing with the Fontan operation these days? Well, this is a review of the data from CHOP, and it was put together by one of our fellows who's now in Houston, actually, Lindsay Rogers, and she reviewed all of the Fontan cases from 1992 to 2009 and published the findings now a couple years ago. And what she found was in the early days of the Fontan operation, we did okay. There was a relatively high mortality, an unacceptably high mortality in our view, but that over the years, as we've gotten more comfortable with the Fontan operation, the mortality rate for the Fontan has gone down dramatically to about 1%, or probably in the current era, even less than 1%. There is still an incidence of the need for an early Fontan takedown. So in some very rare cases, if the Fontan circulation does not appear to be working for a particular child, it is possible to reverse the circulation and recreate the stage 2 circulation, and so we do that in rare cases. But the real question now that we've done so well in the perioperative and postoperative period is what's the long-term outcome, and that's probably what's on the minds of most parents once they get beyond the Fontan operation itself. So another one of our fellows, Tacey Downing, actually two of our fellows, Tacey Downing and Kiona Allen, Tacey's now in Miami and Kiona is now in Chicago, spent a lot of time looking up as much of the follow-up information as could be collected as possible for that initial cohort of patients from 1992 to 2009, and collected all of that data and then analyzed it. So this was the survival curve for all of the patients in that era over time. I think one of the important things to remember when looking at this survival curve is that most of the long-term data comes from people who underwent the Fontan operation early in the experience. because those who underwent that Fontan, for instance, in 2007, per se, wouldn't have data beyond, probably at the time that it was collected, beyond 8 years. So they really didn't contribute to the longer-term follow-up as much as those patients who had the operation in the early 1990s. And in that era, even the early complication rate was substantially higher. So not only do we want to know what the long-term survival is, but we want to know whether patients who have undergone the Fontan will need other interventions. And if you look at, a lot of, in the old days in particular, certainly, hopefully not too often anymore, but in the old days when we would counsel patients, a lot of the counseling said that after the Fontan operation, surgical interventions or interventions were done. The Fontan operation was it, and you can get along with your life, and you never need to see us again. And we know now that that's just not true. In fact, that's part of the motivation for doing the fuel trial, is knowing that that's not true. And in fact, when we looked at the number of patients who required either an additional catheterization or an additional surgical intervention, it was right around 50% actually of all patients required some intervention by 10 years out from Fontan, and the number was even greater by the time patients were 20 years out from Fontan. So I think one of the important things to keep in mind, and I believe this was recognized early on by Dr. Fontan, is that the Fontan procedure is not an anatomical correction, which would require the creation of a right ventricle, but a procedure of physiological pulmonary blood flow restoration with suppression of right and left blood flow mixing. So the Fontan operation does not create normal, but instead what it does is provide essentially a surgeon-created method of trying to deal with what is an atypical or abnormal circulation and make it as normal and robust as possible. So what are some of the inherent characteristics of the Fontan? Well, one of the primary problems of the Fontan is that when the vena cava are hooked directly into the pulmonary arteries, the pressure within the vena cava goes up considerably, such that a normal pressure is in the range of 4 to 5, and for those who have had a Fontan, the pressure is usually in the range of 12 to 18. So a substantial increase in that pressure. The cardiac output is generally lower in children with Fontans, and that's impaired chronotropy is a fancy way of saying that the heart rhythm is generally slower in those who have had a Fontan than in those without a Fontan. There's an impaired ability to deliver a normal quantity of blood across the pulmonary bed, and that's because there's nothing pushing blood across the bed. There's no pumping blood. Instead, it's relying on passive flow, and as a result, not as much blood is able to get across the lungs and back to the heart. That results in impaired filling of the single ventricle. So because there's not as much blood, the ventricle doesn't fill quite as much. And because it doesn't fill quite as much, with every heartbeat, not as much blood can be pumped. And there's an inability to adequately increase stroke volume during periods of increased demand. So this means that, for instance, when you're riding a bike or going on a run or swimming in the ocean or whatever form of exercise or activity you're doing, in somebody with two ventricles, the right ventricle can generate increased force to match the needs of the body. So if more blood needs to go across the lungs, the right ventricle can simply generate more force and push harder, essentially. In those with a Fontan physiology, there's a limitation to that because there's nothing to push blood through the lungs. And so the cardiac output can only be raised to a much, much lesser degree in the setting of increased demand as compared to in those with two ventricles. And then over time, there become elevations in systemic and pulmonary vascular resistance. So the pulmonary vascular resistance in somebody with two ventricles can easily be overcome, except in very extreme cases, and we call that pulmonary hypertension. But in patients with a single ventricle, any incremental rise in pulmonary vascular resistance, which means the resistance to blood flowing through the lungs, creates the need for an increased pressure in the veins. So as resistance rises, the pressure in the veins also has to rise, and that has an impact outside of the heart. And then, and this can happen really in anyone, but ventricular dysfunction does tend to occur later on in children with single ventricles. Particularly diastolic dysfunction is what we worry most about, but there are certainly instances of systolic function. Diastolic function is the relaxing of the heart. Systolic function is the squeezing of the heart. So I hesitated to show this slide. This is a slide we show a lot in scientific presentations. I did not want to necessarily put too much emphasis on this, but in some ways the Fontan, unfortunately, is a man-made form of a low level of chronic heart failure. Heart failure is marked by low cardiac output and high central venous pressure, and when we do the Fontan operation, that is a situation that we create. And that results, and as you guys are learning and probably know already, that results in some side effects on other organs throughout the body. I'm going to switch gears a little bit and talk about what exercise capacity looks like in those with Fontan circulations over time. This is data from an earlier publication that Steve Paridon, who's the co-PI or the PI of the FUEL study, Steve Paridon, he was the first author on this paper now almost 10 years ago, and this looked at a cross-section of children who had Fontan physiology to evaluate what their exercise capacity was. And as you can see just from looking at these numbers, for those, the percent predicted VO2 max or percent predicted peak VO2 is the ability to exercise maximally compared to peers. So for boys compared to boys, for girls compared to girls, and of the same age. So a normal number here would be 100. For somebody who is in better shape than most, the number would be over 100. And for somebody who is in slightly worse shape than most, the number would be under 100. And what the second column, percent predicted oxygen consumption at the anaerobic threshold, is not maximal exercise, but it's the point just before you start to get winded, essentially, when you're doing exercise. That point where you're on the treadmill and you feel like you're breathing, it's hard to keep up with the need to breathe because you're getting tired and you're pushing yourself beyond the comfortable level. That's the ventilatory anaerobic threshold. And you can see that 10 years ago when Dr. Paridon and his colleagues looked at this, that the predicted maximal oxygen consumption was substantially lower across all age groups and got progressively lower as children got older, whereas the consumption at the anaerobic threshold was relatively normal in the younger age groups and got and went down over time. And in fact, this is what we typically see. Most kids do just fine as kids on the playground or even in recreational soccer or basketball or whatever they want to do, up until about the time of puberty when body composition changes, and it's at that point where they have a much harder time keeping up with many of their peers. So one of the important things is not what your exercise capacity is at any particular time, but what happens over time. And this is from an Italian doctor, Dr. Giardini, who looked at exercise change over time. And what he found was that exercise capacity in any individual started near normal at about the age of 9, which is what we just saw, and then went down by about 2.6% per year, such that by the time kids reached young adulthood, their ability to exercise was substantially impaired. So why does this matter? Well, exercise capacity actually correlates pretty well with hospitalization and with illness. In studies of young adults with a variety of forms of heart disease, we found that an exercise capacity below about 45% predicted for age and gender is the threshold at which the risk of heart failure seems to become apparent. So if we look at that 65%, which is what Dr. Paridon and colleagues found, and plot that at the beginning of adolescence or the onset of puberty around age 12, give or take, and then drop that curve by about 2.6% predicted per year, we see that the age at which our patients would be likely to become symptomatic is right around 20 years of age. So the question is, does that actually happen? And the answer, unfortunately, is yes. So in a study of 321 young adults with Fontan physiology who were about 21 years old, the mean or the average oxygen consumption in that group was only about 50% predicted. And as might be expected, 41% of those patients required hospitalization, and unfortunately 9% of those patients either died or underwent heart transplant. So is there a role for medical therapy? Well, in our mind, and this is what Steve and I and many others have spent many years trying to figure out, an ideal medical therapy would alter the rate of functional decline to allow for a longer period of symptom-free survival. So what we're trying to do is adjust that curve. We accept that the Fontan physiology is not normal, but we want to do anything that we can as doctors to change the curve so that kids can enjoy many, many more years and hopefully decades of symptom-free survival. So in our mind, pulmonary vasodilators, that's drugs that relax the resistance within the lungs, make intuitive sense. By decreasing that resistance to blood flow, these medications could allow for improved pulmonary blood flow, which helps with cardiac output. And this is, again, a fancier term, but reduce the delta P needed to drive flow through the pulmonary bed. What that means in English is that the delta P is a difference in pressure between the veins pumping blood to the lungs and the heart on the other side receiving blood from the lungs. If we can drop the pressure head needed to get blood through the lungs, that will improve, hopefully, a host of symptoms associated with the elevation in pressure within the venous system. So this is what we want to do. The black line is the curve that we just looked at. If we can lead to a 50% improvement, then that should give us at least 8 years of improved symptom-free survival across the entire population. And if we can make a 75% improvement, then that improvement can be a decade or 2 decades or even longer. So that's really the goal of trying to do this. We're trying to change the slope of the decline in exercise capacity to avoid some of the complications that occur later on. And in this case, exercise capacity is merely a marker of overall wellness. It's not so much that we care how much an individual can exercise. It's that we want their overall cardiovascular health to be better, and exercise capacity is a marker of that. So PDE5 inhibitors, that's what sildenafil is, that's what sildenafil is, that's what tadalafil is. Sildenafil doesn't have any other name besides sildenafil at this point. Tadalafil is Cialis. Sildenafil, as you probably know, is Viagra. It's a class of medications that's really came into the public knowledge stream based on the use the treatment of erectile dysfunction. It turns out, and we've been working with the people who were instrumental in the early days of discovering Viagra, it turns out that the medication was created as a heart failure medication, a blood pressure medication. So the original use was to help control blood pressure. It did a terrible job of that. So it only improved blood pressure very slightly. And so Pfizer was going to throw the drug in the waste bin essentially and move on to something else. But there was a small team within the group studying the drug that said, wait a minute, we see a really interesting side effect of this drug. And that's what created the market for erectile dysfunction. But PDE5 inhibitors are also potent pulmonary vasodilators, so they relax the vessels within the lungs. And in fact, currently they're the frontline therapy for anybody with pulmonary hypertension, whether or not they have associated congenital heart disease. PDE5 inhibitors, because they've been used so long for erectile dysfunction and now for pulmonary hypertension, have a very long track record of relative safety. And data is emerging from the Fontan literature suggesting that these might have a role in a therapeutic role in this population as well. So there have been a number of studies. I'm going to go through these very quickly, just in the interest of time. This was the very first study looking at sildenafil in those with Fontan physiology. People came in, there were a total of 27 subjects. They came in for an initial exercise test just to train themselves on the equipment. Then they came back about 2 weeks later for a second exercise test. 2/3 of them were given a single dose of sildenafil after that test, and 1/3 was given a placebo. And then they had a third exercise test 2 hours after the first one. What we saw was an improvement in cardiac output, the amount of blood that the heart is able to pump in a given minute. And that was true even without exercise. So just at rest, those who had taken sildenafil were able to pump a much more normal cardiac index. 3.7 is a pretty typical number for those who have 2 ventricles, and 2.9 is more typical for those with single ventricles. And similarly, cardiac index was able to increase at peak exercise. Pulmonary blood flow, which is PVF index, pulmonary blood flow went up as would be expected with the increase in cardiac output. And as was mentioned before, there really was only a very mild change in blood pressure, because while these medications are good for some things, they are not good for their initial attempted indication, which is as a blood pressure medication. A more invasive but more interesting subject was done in 2014, and this was at Duke. There were 9 subjects with Fontan physiology who underwent a cardiac catheterization, during which they were administered a single dose of sildenafil, and then measurements were made before and after that dose. In this group, the saturation in the veins, which is an indication of the amount of cardiac output, went up dramatically, actually more dramatically than I would have expected. A really nice result there. The pressure within the Fontan circulation and the pressure head needed to push blood across the lungs both went down. So that's a very good result. And again, pulmonary blood flow went up, systemic blood flow went up, and the resistance to blood flow in the lungs went down. In another 2014 article, this one from the Netherlands, in this case, there were 10 children, or young adults actually in this case, who were enrolled in the study. This was a relatively invasive study and not something that would be easy to replicate because all of the subjects had an arterial line placed, which is an intravenous line in an artery, along with the central venous line, which is a big intravenous line within one of the veins, and one of the big veins in the body. Then in this situation, they all 10 subjects performed MRIs and exercise MRIs, which is essentially riding an MRI compatible bike in an MRI machine. So not super easy to do, but there are actually these devices that exist, so you can ride a bike while lying down in an MRI scanner. Not something that we want to do on an everyday basis, but something that is sometimes potentially useful. Everybody who was enrolled got a single 50 milligram dose of sildenafil and then had their testing repeated. So the red line here is what happens after sildenafil, and the blue line is before sildenafil. And there you can see there's rest, there's low exercise, moderate exercise, and high exercise. And at all levels of exercise, including rest, the cardiac index, again, the amount of blood that the heart is able to pump in a given minute, went up significantly, most significantly at high levels of exercise, suggesting that by lowering pulmonary vascular resistance, kids were able to keep up more with the demands of the body at higher levels of activity. One of the interesting things that we found was that the heart was able to squeeze better after a dose of sildenafil. So EF percentage is ejection fraction, and that refers to the amount of blood that fills the heart that the heart is then able to eject to the body in any given heartbeat. And as we saw before, that went up with every level of exercise, and again, most notably at the highest levels of exercise. So what about the pressure in the Fontan circulation? Well, even with the increase in the amount of blood flowing, the pressure within the pulmonary artery, which is the Fontan circulation, went down, again, most dramatically at high levels of activity, and the pulmonary vascular resistance, which we would have anticipated dropping, did indeed drop at all levels of activity. So all of this is good short-term data, but the question isn't really, are these drugs good in the short term, but are they good in the longer term? So we underwent a trial, which some of you may have participated in, those of you who are in the Philadelphia area, a number of years ago here at CHOP, in which we looked at the impact of sildenafil over a 6-week period on kids who have undergone the Fontan. In this study, all of the children who participated were randomized either to sildenafil or to placebo, which is a sugar pill that looks the same as the sildenafil, for 6 weeks. They had exercise testing at baseline and then the conclusion of their 6-week period. They then had a 6-week period of nothing, no medication at all. And then they had a 6-week period of the opposite. So if they had sildenafil at first, they had sugar pill second. If they had sugar pill first, then they had sildenafil second. And neither we nor they knew which order they were getting the sugar pill and sildenafil. So we were able to compare the results of each of those cohorts to themselves, which was a nice way of looking at it. So we did not find an increase in maximal oxygen consumption for the entire cohort over that period. But what we did find in a very small sample of children was an improvement in oxygen consumption or a trend towards improvement in oxygen consumption at the anaerobic threshold. So again, that means that that's that period right before you get winded or right as you're getting winded on the elliptical or treadmill or whatever exercise you're doing. Right when you have a hard time catching your breath, that's the anaerobic threshold. And what we saw was that we were able to push that threshold a little bit. And that was particularly true in those who had what we termed heart failure, which was characterized by a BNP, which is a lab test greater than 100. And also, for whatever reason, in those with left ventricles or mixed ventricular morphology, the result was more pronounced. Now, again, this was a very small sample size, but what this showed, or what this implied to us, was maybe this medication does work, and we need to look at it more closely. The other thing, which was really interesting and continues to be replicated, is that it appears that sildenafil helps the squeeze of the heart too, and we're trying to do additional research to understand why that is. But there's something called the Myocardial Performance Index, or MPI, which is a measure of how well the heart squeezes, and a lower number is better. And we were able to demonstrate that that number decreased with the use of sildenafil. So that was a really interesting finding. I'm going to go on a quick tangent. One of our current fellows is working in a basic research lab to see if he can understand why sildenafil will improve the dynamics of the heart, improve the squeeze of the heart, and he's making really good progress, and hopefully we'll have that information to share with you and with people in general in the coming months. So side effects, a key, obviously, issue. We certainly don't want to do more harm than good with any drug that we give. So we want to be very, very careful and make sure that our medications are safe. So here is the side effect profile of sildenafil versus placebo in our CHOP study. You can see that headaches were somewhat more common. Flushing was also somewhat more common. But really, those were the only two symptoms of note. Dizziness happened, but with no different frequency in the sildenafil group than the placebo group. There were 2 kids who had some nausea and vomiting. Hard to know what that means. One person had abdominal pain, one person had a kidney stone, one person became photosensitive, one had a rash. In the placebo group, there was 1 report of diarrhea, 1 kid had low blood pressure. Again, that's low blood pressure without any medication other than a sugar pill, muscle pain, ringing of the ears, and shakiness, which is tremulousness. Back to the headache and flushing. In our experience, those symptoms tend to happen early in the course of the drug and tend to go away over time. The flushing is non-painful. It almost looks, I don't know if any of you have seen it, but it looks as though the patient has been outside on a cold day and come in from that, and just the redness in the cheeks. It doesn't hurt them. It's not warm to them. They wouldn't even notice it unless somebody told them or if they were looking in a mirror. The headache can be more substantial. We've had kids who have needed to take medications for headache for the first couple of days when they're on sildenafil or other PDE5 inhibitors. But after a couple of days, the headache does tend to resolve and does not seem to cause a long-term problem. So that now brings us to the Pediatric Heart Network Udenafil trial. So the first trial that we did with Udenafil was what we call a phase 1, phase 2, and this was really just looking to try and identify what doses would be tolerated of Udenafil and which dose would work the best. So we tried a number of doses, once daily and twice daily, to look at which ones achieved the highest concentration in the bloodstream and were able to maintain that concentration over time. And then we had 6 participants who did only exercise. So the 30 participants in the medication cohorts also did exercise at the beginning and end of their little 5-day trial. Similarly, they had an echocardiogram and something called an endopat, which is a little finger cuff and blood pressure measurement, which looks at how well the blood vessels essentially respond in a given patient. The outcomes of this phase 1, phase 2 study showed that Udenafil was well tolerated at all dosing levels, not a lot of side effects at all, in fact probably fewer than what we saw in our sildenafil trial. And the 87.5 milligram twice daily dose achieved the highest serum drug level. So in other words, the level of drug in the body was the most consistent, so it didn't have as many peaks and valleys as the once daily dosing, and it achieved a nice steady state level, which we think will provide the best effect. The other thing of note, which I didn't mention on this slide, is that while there was not an improvement in over 5 days, which we wouldn't have expected really in exercise performance, there actually was again an improvement in that myocardial performance index. So even after 5 days at a dose of 87.5 milligrams twice a day, there was a suggestion that the heart squeeze was somewhat better in this population. It's hard to know whether that heart squeeze is better because the squeeze itself is better or because the heart is filling better and therefore better able to empty, but it certainly did catch our attention and was very encouraging. So now on to the FUEL study. So the FUEL study is a phase 3 study, which means it's a trial designed to tell us whether this drug works or not. It's a randomized trial, which means some children will get drug and some will get placebo. Double blind, which means neither we nor the participants will know which arm of the trial enrollees are in. And it's a 6-month-long trial where the participants will take either Udenafil or the placebo twice a day for that entire 6 months. And it's really to look and see whether this drug works. We're hoping to get 400 total enrollees, 200 in the Udenafil group and 200 in the placebo group. And we're up to about 30 sites throughout the United States, primarily in the United States, about 25 in the United States, 2 in Canada, and 2 which are just coming online in the Republic of Korea, which is South Korea, of course. The aims of this study are to determine the impact of Udenafil on exercise performance relative to placebo over a 6-month time period. And secondary aims including looking at measures of ventricular function, how well the heart squeezes, endothelial function, how well the blood vessels work, and markers of heart failure, again, what that serum BNP level looks like, so what that lab value is. And one of the primary objectives is to carefully evaluate safety over the entire study period. So we're very rigorous at asking people about what side effects they're feeling. Anybody with a Fontan physiology, well, not many people, most people with Fontan physiology between 12 and 19 years of age are eligible to enroll. The participants need to consent if they're over 18, or their parents need to consent if they're under 18, in which case the participants would also need to sign what's called an assent. Given the limitations of the study, we need participants to be fluent in English, Spanish, or Korean. If we really needed to translate documents into other languages, we probably could do that. Because we use exercise equipment, there's a minimum height requirement of 132 centimeters, and the FDA has mandated that we have a minimum weight requirement of 40 kilograms. We are trying to avoid taking patients for whom it would be difficult to ascertain whether sildenafil has provided a benefit. So for those who have been in the hospital for heart failure within a year of the trial, or who are undergoing evaluation for heart transplantation, or essentially who have active protein-losing enteropathy, plastic bronchitis, or liver cirrhosis. And that's liver cirrhosis not just by ultrasound, but actual, truly documented liver cirrhosis, which is actually relatively rare in our population. But we would avoid recruiting these patients into the trial. This is a whole bunch of other exclusion criteria, but basically all of them essentially say that we want patients in whom we're able to measure the impact of sildenafil without other complications. So we're not including patients with pulmonary vein stenosis or single lung physiology or severe kidney disease or severe liver disease. We're also not taking patients who have been on a pulmonary vasodilator within 3 months of the study onset. And we're not, in the rare circumstance that somebody might have been exposed to sildenafil, if they were intolerant of it, we wouldn't recruit them into the study, although that will almost certainly not happen since sildenafil is not available commercially. And then for those who are on many, many medications, who may have seizure disorders or or who require a number of more complicated medications for other reasons, if they interfere with the metabolism of sildenafil, we cannot, unfortunately, include them in the trial as well. This is just, these are available if you want to look at it. One of the more interesting ones is for those who are addicted to grapefruit juice, we can't enroll you in the trial because there's an interaction between grapefruit juice and sildenafil. So certainly folks can drink small amounts of grapefruit juice, but patients would need to limit their grapefruit juice exposure. All right. So here is a scheme of how, this is a very complicated slide, and I apologize for that, but we'll go through it. This is what happens through the fuel trial. There's a baseline visit. If patients give consent, then we start to review eligibility criteria. If there is no consent given, then obviously they're ineligible and don't participate. For eligibility criteria and testing, we do a baseline EndoPAT, which is that endothelial function test, an echocardiogram, and an exercise test, which includes an EKG and lung function testing. And then we do a bunch of labs for our female participants. We ensure that they are not pregnant with a pregnancy test before enrolling them. Then patients do an exercise test, and if they're able to achieve maximal exercise, a maximal exercise test, then they can enroll. If they can't achieve a maximal exercise test, then they're given additional opportunities to try again if they would like to. And if they're able to, at some point, produce a maximal exercise test, then they can be enrolled. Then we randomize to either sildenafil or placebo. And then if we give the first dose of drug, either placebo or sildenafil, in the study center, and we observe for a series of a few hours after the initial dose to ensure that it's well tolerated. We do a series of vital signs, and then enrolled subjects do a 6-minute walk. We look at vital signs during and after the 6-minute walk to ensure that there's nothing worrisome. This was added at the insistence of the FDA. They were concerned that we would give kids the drug for the first time while they were home, and then they may go out and play basketball or go for a run and have an untoward event as a result. So they suggested, and we think it's a reasonable idea, that we observe the first dose in the hospital. That being said, we have not had anybody who's had trouble in any of our trials, whether sildenafil or sildenafil, tolerating any of the doses of drug from that perspective. After that first drug, first dose, patients go home with the medication or with the placebo. They then get a series of phone calls from our study coordinators, and there are 2 additional in-person visits at weeks 2 and 13 where we review the course of the study so far and check vital signs again. These visits were put in at the insistence of the FDA, and in our view, they're a little unfortunate because they do represent a pretty significant inconvenience to families, particularly those who are coming from farther away, and we haven't seen anything clinically meaningful at these visits so far. I will say that we are very close to partnering with visiting nurse associations so that subjects would no longer have to come and see us, but instead we could send a nurse out to see you. The whole visit takes about 10 minutes. So for those who live hours away, it seemed ridiculous to us and to many of the families that the families would have to drive all the way in, get their heart rate checked and blood pressure checked, and for females, get a urine pregnancy check, and then just go home again. So rather than continuing to put our families through that, we've partnered with visiting nurse associations who will do that for us. So I sort of went through this already. This is just the first day visit where we do go through consent and all the basic testing. We will make sure that all participants do need to come in fasting because the endopat test has to be done in the fasted state. And so there's a break between that test and exercise, and we feed everybody up to make sure that they'll be able to do exercise testing without feeling faint. As anybody knows who's tried to exercise rigorously when not eating, that does not typically go well. So we do have a built-in period for a snack. These are the weeks 1 to 4 follow-up where our study staff will contact everybody. So study staff at CHOP, that's Stacy Wojciechowski. At other centers, it's whoever the primary study coordinator is typically, and they'll call you to check on side effects and any adverse events, check to make sure that all the drugs, all the study medication has been taken, and then we have the in-person visit at 2 weeks and the in-person visit again at 13 weeks. We're hoping to replace those with a nurse sent out to families instead of asking families to come to us. So then the end of study testing is really a repeat of the study entry testing where we do the endopat test and the echo, and then give a light snack, and then do the exercise test. Sometimes we do the echo after the snack. Either way is fine. And this is done at the end of 6 months, plus or minus 2 weeks. So there is a fair amount of flexibility in terms of when specifically kids come back in for this. If there's a family vacation or some kind of camp or a school test or whatever, there's a fair amount of flexibility around that. So if somebody wants to withdraw early, if they've gone through a month or 2 and they say, you know what, this is great, but it's not for me, that's of course totally fine. There will be some families or some kids who feel that way, and that is totally up to them, and there will be no pressure to continue if they choose not to continue. If they're willing, we would like them to come in and do that end of study testing. They can do it early. We'll of course write down why they're choosing to withdraw, whether it's from symptoms or study fatigue or whatever else it is, but we'll record that. And then our coordinators will do some paperwork to document that. All right, so this brings me now to the fuel open label extension. I have about 2 more minutes total of talking. The open label extension is really a safety extension where we're trying to look at an additional 12 months of treatment on sildenafil. This is done in an abundance of caution. If we are going to use this drug, we really want to know that it's safe. So the fuel trial will give us 6-month safety data, and the open label extension means that open label means that anybody who wants to continue on will get sildenafil. There's no placebo here. So all 400 participants in the fuel trial will be offered enrollment in this. They'll then be given sildenafil, 87.5 milligrams twice a day. And basically the main thing is just evaluating to see whether they have any side effects. It may be that there are no side effects in 6 months, but once you're on it for 11 months, you start to develop side effects. We want to know that before we give kids this drug across the country or routinely. So it's the same 400 subjects and the same 30 sites. The testing is the same. We are doing that endopat, echo, and exercise test at the beginning and end of the open label extension. Often we can use the fuel end of study testing as the baseline testing for the open label extension. And of course, a subject can participate in fuel and then say no thanks to the open label extension. That's totally fine. Of those who have finished the fuel trial so far, I'd say about 80 to 90% have continued on into the open label extension. And I'm going to stop there and turn it over to, we're fortunate to have a couple of folks who have children who have participated in the study, or in one case has participated in the study, to talk a little bit more about this.
Thank you. This is Jody again, Dr. Goldberg. That was really fascinating, and I learned a lot today that I didn't even know before, and I've been looking into this for a while, so thank you so much. That was fascinating. The first person who's going to speak, we learned all about the trial now, and we felt like parents and patients, prospective patients would want to know, so what is this really like from a parent and patient perspective? So first we're going to have Jennifer Perez tell you a little bit about what it's like from a parent perspective. Jennifer?
Hi, good afternoon. I'm in Charlotte, North Carolina. My son Andrew is seen at the Children's Hospital of Philadelphia. He is 12 and a half. He will be 13 in August. He has been involved in single ventricle survivorship program at CHOP since he was 5, and we were approached, since we're so far away, we come up in the summer when school is out, and we were up this past summer for our single ventricle survivorship program visit, and we were given information on the fuel study, and we took time to think about it, go over the risks and the benefits, and we decided that it would be a good idea to go forward with it. And after talking with Andrew, going over everything, the tests and everything, he thought it was also a good idea too, so we moved forward with it. We started the trial in the middle of November. We came up there for the trial, for the beginning part of it, and we actually come up to CHOP next week for the last part of it, the last testing, and then the following day we will start the open label testing. And so far it has been totally fine. He's done great with it. The only side effects, which I can't really say definitively if they are side effects of the medicine or not, have been headaches in the very beginning of starting the medication. He's not a child that gets headaches very often, but he has complained intermittently, you know, throughout his life of getting headaches every once in a while. So not quite sure I can contribute that to the medication or not. But I will say that the headaches have gotten less and less over time. So we are nearing that end of the trial. And again, we don't know if we're taking the medication or the placebo. And he's been doing great with it. He's almost 13, you know, so he can verbalize what he likes and he does not like. And the only thing that he has said from the very first test is he does not care for the endopat test. They hook up both of their arms to a blood pressure cuff, and it's probably about a good 5-10 minutes long, and they squeeze it, and that was his least favorite part. He didn't mind the blood draws, and he didn't mind the exercise, stress test, and all that stuff, but that was his biggest complaint. So if that's his biggest complaint, then I'll take that. So.
Thank you so much, Jennifer. And it's always good to hear from a parent perspective and learn a little bit more about what you're seeing with your child. And now we're really excited to have a patient with who is in the study, Lucy James Olson, and she's going to tell us a little bit about why she entered the study, why she wanted to do this, and how she's done with it and how it's impacted her. And if we can move to the next slide. And Lucy?
Hi, everyone. So I actually just finished up the fuel study. I had my final appointment in early April. The exercise physiologist I saw measured my exercise capacity at the low end of normal, which, like, low end of a non-Fontan patient, which is great. I have hypoplastic left heart syndrome. I had a Fontan procedure with no fenestration, and I haven't had any really invasive procedures since my third stage, which was when I was 1. So I'm able to live a relatively normal life that's not interfered with by my heart defect, but my cardiologist recommended me for the study because we had a resident physician here at my hospital, Nemours in Wilmington, who was, involved and was trying to recruit people, and it seemed, well studied. It seemed like there was, enough positive effects in preliminary studies for it to be beneficial, and I really, I noticed improvements in my, not only my exercise capacity, but just, as David said, when I was resting, I felt better. I felt more alert. I didn't feel as sluggish as I have in the past. Right now I'm on 81 milligrams of aspirin and 25 milligrams of atenolol. In case anybody else has taken those, there's no interference. And I'm actually planning on starting the open label extension as soon as possible because I really had no noticeable or, profound side effects that bothered me to the point where I would ignore the positive effects that I felt, in favor of the side effect. So yeah.
Thank you so much, Lucy. We really appreciate you being here and giving us a different perspective on this as well. So now we'd like to move into questions our panelists have presented, and we do have a couple questions already in writing. Again, if you want to write them in the chat box, we'll read them. If you would like to use the hand-raising feature and ask them out loud, I will look at that and unmute you, and you can ask them. So the first question is from Jeff, and Jeff asks, when the patient starts the decline showed on the previous chart, the AGE function, do the patients present symptoms like lower O2 sat numbers, something the patient or parent could easily monitor? And I think that's for you, Dr. Goldberg.
Probably. No, unfortunately, there isn't really any overt thing to measure other than just looking at exercise capacity over time. I think in some cases the patients may feel less well, but like anything, if the change is really incremental, you may not even notice it. For those of us who exercise for a while and then stop exercising, we don't really notice that we're not feeling as well when we stop exercising, but once we start again and get back into it, we say, boy, now I have much more energy. And it's sort of that incremental change that happens in patients with Fontan physiology as well.
Thank you. We have another question also that is, what do we know about this class of drugs' long-term effects on other systems, liver, kidneys, et cetera, as it's not currently used as a maintenance drug and taken more on demand? I think that's an assumption, question mark.
That is a great question. That's actually, so it is used for erectile dysfunction, it's used primarily on demand, but for pulmonary arterial hypertension, it is actually used as a maintenance drug. And Dr. Hanna, who's our pulmonary hypertension expert at CHOP, reviewed our internal data about a year or two ago, and as far as he could tell, there were no significant long-term side effects. Now, I will say that sometimes in older adults who have friable blood vessels in their eyes or their ears, who take a very high dose, there have been of sort of a bluish tinge to their vision or a ringing in their ears. But we really have not seen that in a pediatric population. Dr. Hanna hasn't seen that much at all, or at all, in the pulmonary hypertension group. And CHOP is has one of the largest populations of children with Fontan physiology anywhere, and some of those children are on sildenafil, and we really have not had any significant side effects in that group of children to date. Now, no matter, the total experience is probably only about 5 to 10 years, So I can't really answer the question beyond that time frame, but I can tell you that the data so far in the 5 to 10 year time frame is reassuring. I think even if sildenafil becomes a drug that is used in a widespread fashion, we will be very careful about maintaining a registry and continuing to follow side effects over time, because as I said, with any intervention, you want to make sure that the intervention, the positives of the intervention outweigh the negatives.
Wonderful, thank you. And then we have a question from Rochelle, and then Steve Paridon is using the hand-raising feature, so I'll ask the question first. What is the main difference between sildenafil and sildenafil?
The main difference, there's some subtle differences in the molecular structure of the two drugs. The functional difference is really in how long the drug stays in the system. Sildenafil is a drug that's relatively quickly eliminated from the system. So in order to get a prolonged benefit from it, it has to be taken 3 times a day. Sildenafil can be taken twice a day and stays in the body substantially longer. So when we initially conceived of the study, we thought about using sildenafil, but I'm not on medications often, but even when I have to take amoxicillin 3 times a day, I struggle with that. And I'm a grown-up, not an adolescent, and so we didn't really want to create a situation where drug adherence was going to be difficult. So sildenafil twice a day means you can take it in the morning when you brush your teeth and at night when you brush your teeth, and then not think about it again throughout the day. You don't have to take it at school. You don't have to take it during sports. You don't have to take it any other time besides the beginning and end of the day. So that's really the reason why we're studying sildenafil on a large scale and not.
Yeah, and that would bring up a good, maybe Jennifer and Lucy, Jennifer first and then Lucy, you could answer, has there been an issue, speaking of that, with remembering to take the medication? Is it difficult to take it twice a day? So Jennifer and then Lucy, if you could answer that question.
No, it hasn't been difficult to remember. He takes aspirin, 81 milligrams, and he also takes aldactone for some liver issues that have been going on for the last few years. So he takes his study drug in the morning with his aspirin, and then he takes it again at night with his aldactone. So it hasn't been a nuisance or anything. He just takes it along with his regular medication, so it hasn't been hard to remember.
Okay, great. Yeah, thank you, Lucy.
I would definitely agree with that. I take atenolol twice daily for, I'm assuming, similar liver function issues, and taking 2 twice daily meds, it hasn't really been a huge adjustment because I take 3 pills in the morning and 2 at night, and it's easy to remember.
Okay, great. Thank you. All right, I am unmuting you, Dr. Paridon. You are unmuted.
Hi, I hope everybody can hear me. This is Steve Paridon. I had been listening on Dr. Goldberg's excellent presentation. I just want to take the opportunity as the overall PI for the project to thank everybody, both all the participants and certainly our subjects who have agreed to participate and share their experience with everybody, as well as all the parents and family members who took the time to listen in to hear what we had to say about the trial.
Thank you so much. And again, this is being recorded. We will provide the link to the recording to all of you, and you will be able to get that. And the Pediatric Heart Network, Mended Little Hearts and Sisters by Heart, all thank you for being on this call today.